now for the last part of the session, last but absolutely not least, going to be moving on to Dr. Martin Marshall from the Royal College of GPs. And I know that I've got a lot of colleagues who want to come in. I just really wanted to ask one question, if I may, following on from Sarah Owen's question just now about dementia care. And GPs have an absolutely crucial role in dementia diagnosis. But as most of the memory clinics are closed, are you worried that people aren't getting diagnoses at the moment that could mean they're not getting the additional care they need?
Yes, I think that is a very real concern. And of course, it's relevant to dementia, but it's relevant to many other conditions that we're looking after. Particularly in the early days of the crisis, a lot of services that we wanted to refer to had shut down. Progressively, they're opening up, and that's getting easier for us, I think. Dementia services, by and large, still quite difficult. They're not being regarded as a priority, however important they are to the patients that we're serving. So we are looking forward to them as and when that's possible.
Thank you very much. Luke Evans.
Thank you, Prof. Marshall and Chair. Thank you for all you did. Before I speak any further, I should declare I was a member of the RCGP and have been an AIT rep for several years. So I should put that out there. But in light of that, actually, I've been contacted by AIT reps who are very concerned, particularly about the ST3s who are due to finish. Could you just explain, if I could have a very quick conversation about the role you've played with the GMC and indeed the AIT reps and the RCGP on getting people qualified, both protecting the public, but also allowing people to take their jobs in August?
Yes, thank you very much indeed, Luke. So this is a very significant issue for all of us. So we had to postpone the exam back in the middle of March because of the crisis, but particularly because of social isolation, and that left around about 1,400 trainees who were expecting to qualify in August, at least initially unable to do so. And we've been working very hard with a range of different partners. This isn't just a college business. College sets the exam, but we've been working with the General Medical Council, who set the regulations. We've been working with the education bodies in all 4 countries. We've been working with governments as well in order to try to find a solution. It looks as if we are about to do so, which is great. So we hope that the majority of the 1,400 trainees who need to qualify and get into the workforce in September will be able to do so. There still will be some that won't be able to, particularly those, for example, who've got health problems, those who simply don't feel ready to sit the exam when their training has been changed so dramatically over the last 2 or 3 months. So we hope that we're going to get there with a solution.
So would that be an outcome 10? And then have you got a date for when this is likely to happen? Because people have got jobs starting technically in August who are very, very concerned that are they going to be able to take those substantive posts up?
So we're very, very aware of that. And I think that the majority of people who want to take up posts, who've got posts to take up, will be able to do so. What we've got to do as a college, of course, is recognise the needs of the service, the needs of the trainees, but most importantly, our job is to protect the public, to make sure that doctors are safe when they become independent practitioners. And that balancing is difficult. As I say, there's many different cogs here that need to work together, but we're confident that, indeed, we've got a meeting this afternoon, we're confident we'll be able to come up with a solution that satisfies the needs of most trainees, but most importantly, satisfies the needs of the service.
Can I flip it on its head now? From the top end, we've had over 5,000 retired GPs come back to help the service. Have you put any work or effort into making sure they will, or if they so choose, stay on to help increase GP numbers?
Yeah, we know there's been a massive workforce crisis in general practice, and we know that a lot of people in their even mid-50s, late 50s have retired simply because the job became really quite undoable for many people with the bureaucracy, with the increased workload that they've had to face. So it's been extremely gratifying to see a number of those people who left in frustration often from a job that they love, wanted to come back in order to support the service during this crisis. We're looking at ways of supporting them, getting them back into the service, and we would love it if we could create a general practice that makes it attractive for them to want to stay on, because you need experienced clinicians.
And finally, one last question on the wider nature of thinking about when we start to get back to normal. The PCN and the DES that was put forward with the service spec, is warmly welcomed in terms of principle, what it's trying to achieve, but the implementation, not so much. Has the college got a position on where that should go, both now, forward in terms of the implementation, and should there be any changes considering the workload that may well now be developed because of the coronavirus outbreak?
Yeah, so we're very supportive of practice networks, of primary care networks in particular. We see that as being a really important model, and we see in many parts of the country it working exceptionally well. PCNs have actually been given a lease of life by the coronavirus crisis, because the sharing of services across practices, particularly PCN-based hot hub centres for COVID, for example, has given them a real lease of life. So we would expect and hope PCNs to be more embedded in the service as a consequence of having to work through the crisis.
So you actually might think it may be beneficial going forward because those previous boundaries have now had to change overnight?
Yes, I think that's right. In so many ways, general practice has changed as a consequence of this crisis, and I'm sure we'll come back to that in subsequent questions, exactly how it's changed. I think the desire to work collaboratively between general practice, but also between general practice and community services and hospitals services as well, has been really dramatic. The pace of change has been amazing, and I think a real testament to the work that general practitioners and their staff have really had to put in.
Thank you for all you do. Thank you.
Thank you. Laura Trott.
Thank you, Chair. Professor Marshall, you alluded in your answer to the previous question about the changes that GPs' practices are undergoing. Many people are finding the virtual consultations to actually be incredibly beneficial. What will be required for these to carry on after the pandemic?
Yeah, so there's been a dramatic change. So prior to the pandemic, about 70% of consultations in general practice were carried out face-to-face. Now, according to the data, it's about 23%. I suspect it might even be less than that. That's been enabled, of course, because it had to be. That's the reality of not being able to provide face-to-face care except when it's exceptionally required. Most importantly, it's been enabled by having access to the technology and the investment that's been put into the technology. So, for example, in the early days of the pandemic, I received a laptop fully loaded with patient software with a VPN connection that allowed me to access safely all of my patient records, and I've been able to deliver surgeries remotely. That should be the norm. The cost of that laptop was a fraction of it. Would be a few days' work for a GP or for a practice nurse. So that very relatively small investment in developing technology to allow more remote consultations is absolutely spot on. I think the future will be somewhere between where we were and where we are. I don't think that 70% of consultations had to be carried out face-to-face before the crisis, and I don't think 23% is right either. Maybe 50% is right. The online consultations or remote consultations are really good for transactional problems, which are quite common in general practice. They're not so good for problems that require relationships, that require you to understand, to be able to lay on hands, to be able to use your sixth sense, to see non-verbal communications, all the things that are the essence of general practice. So we need to make sure that we get the right balance. And that's, I guess, one of our biggest challenges as we emerge from the crisis.
Thank you. And just a quick follow-up from me, which is that the piece of technology that you described there sounds ideal. How confident are you that GPs across the country do have the kit they need to continue carrying out these consultations on an ongoing basis, albeit in a balanced way with physical consultations as well, as you described?
So a growing number do, but many still don't. Many still don't have the actual equipment itself, and many of them don't have the support to be able to set up and use the equipment, or indeed the training that's required to carry out remote consultations, which is a different kind of style of consulting. So I think the investment that has been made has been helpful. More investment is required, and as I say, it's a fraction of the total cost of dealing with a crisis or the total cost of running primary care services. It's a small investment that's required, which could have a massive impact on our ability to provide a different kind of care for those who will benefit from it.
Thank you.
Thank you. And now we've got another of our resident GPs, James Davis.
There we go, unmuted. Thank you, Chair. Just building on that, really, in relation to care or telemedicine, I should say. I've seen it being used very successfully, but one of the concerns that's been raised is that there is some degree of variation as to how much it is being used, and whether sometimes there are people who are not being seen face-to-face or on home visits who should be, and perhaps we're relying a little bit too much sometimes on community care colleagues. I wonder if you have any views on that. And allied to that, in terms of death certification and the fact that some of the commonest causes of deaths normally, heart disease and stroke, for instance, are anecdotally not featuring as they might in death certification. And is there a worry that we are missing some of what's going on out there? Thank you.
Yeah, so as far as death certification is concerned, this has been an interesting and fast-moving field, because we're all have been dealing with more deaths. We're preparing for a larger number of deaths, particularly in the community, and I think it's certificates. We always try to put the most likely diagnosis. If it's likely to be COVID, we want to put COVID. The major problem here has been the lack of testing, which has meant that we haven't been able to always put COVID when we think it might be likely, or maybe we've just had to suggest it's most likely to be COVID. So when more testing takes place, I think it'll be much easier for us to be able to fill out death certificates in an accurate way. And that, of course, is extremely important for us all. As far as the use of technology is concerned, you're absolutely right that some people are using it more, some people are using it less. We know that there are potentially risks in not being able to examine patients and not being able to see patients. I think that's a judgment that we're learning as we go along. We're making sure that we do assess people face to face when they need to be assessed. Sometimes we are using other services, like referring to hot COVID centres. Sometimes people who are doing visiting, for example, to care homes, are making those visits instead. But the vast majority of GPs are examining patients, are seeing patients physically when they need to do so.
Thank you.
Thank you. On to Amy, please.
Thank you, Chair. I had real concerns prior to the COVID-19 outbreak that young people with cancer symptoms were not presenting to their GP. And this crisis has just made those concerns even more real. What work has been done to ensure individuals, and I place particular emphasis on young people with signs and symptoms of cancer, that they don't experience delays in diagnosis due to COVID-19?
Yeah, so I think some of these issues were discussed in the previous section under cancer, and of course this is a very real issue. We know that a lot of younger people don't access health service of any sorts, including general practice services. And one of the issues there might well have been the difficulty with making face-to-face appointments, or discomfort with face-to-face appointments. So one hopes that the use of remote technologies, particularly online technologies, even the basic telephone, will improve access to young people, and that will help us diagnose a whole range of conditions, not just cancer conditions, but in particular mental health conditions as well. So one hopes that the different approaches towards different modes of consultation will mean that services for people who are currently not as well served as they need to be will improve.
Thank you.
Thank you very much. And finally, Taiwo, you had a question.
Thank you, Chair, and thank you, Professor Marshall. Given that patients discharged from hospital may need to be rehabilitated back to community care, what challenges are healthcare professionals and community teams facing, and how efficient is this referral process?
Yeah, so the referral process has been complicated by the crisis, as one would expect, particularly in terms of the availability of specialist services that we need to refer to in general practice. So a lot of the services that we would like to refer to simply haven't been available, or are only just coming back online for us. One of the really positive things that's come out of this dark cloud, another silver lining, if you like, that's come out of the COVID crisis, has been better communication and more effective communication between general practice and hospital services. And there was a reference earlier, for example, around cancer services to online consulting. In some cases, some parts of the country, three-way consulting between a patient, a GP and a consultant online. Those are the kind of things that we need to really build back into the service. And I think one of the big challenges that we have in general practice is to identify which of the COVID-related changes are good and need to be sustained and need to be embedded back into the service, and which ones are not good for patients, perhaps not good for the NHS, and need to push back on. And one of the things that I'm particularly keen on pushing back on is administrative workload in general practice. It has been a massive problem for general practice. We know around about 25% of clinicians' time is spent doing things which often don't add very much value. We've seen a dramatic reduction in administrative tasks in general practice, and that has freed up space that many GPs haven't seen or recognised for 5 or 10 years. What we need to do is make sure that the default position is that bureaucracy will come back again. We need to really make sure that it doesn't, and push hard. And that's in areas like contractual obligations, in areas like regulation, organisational regulation, and professional regulation. I'm not saying all of those are bad things. I'm just saying that they became disproportionate, and an opportunity to create space by reducing administrative workload would be massively beneficial for general practice.
Thank you.
Thank you very much indeed. Dr. Marshall, I just wonder whether I could ask you, you're one of the most senior GPs in the country, and there'll be lots of people at home thinking about whether they should go to their GP with a concern. You've heard the whole discussion this morning about the drop in cancer referrals, the drop in young people's mental health referrals. What's the message you would give to anyone at home about accessing GP services right now in the lockdown?
So the message, as indeed other witnesses have said, is that general practice is open. It's operating in a different way. I think we need to understand why patients aren't accessing both general practice and other services as well. And partly, a lot of patients are saying, actually, they really respect the NHS, they want to look after it, and they don't want to put pressure on it. That was certainly the case in the early days. Some patients are worried about picking up infections. Some people are worried about the door being closed, and some people think the services simply aren't available. So the message from us in general practice is open. Particularly for significant conditions that need to be prioritised, whether they be acute health illnesses, whether they be mental health problems, whether they be potential cancer, whether they be preventive issues like childhood immunisations. So right now during the crisis, you might not get normal care. It's very likely that you'll be triaged. It's very likely that you'll receive online care, but general practice is open to you.
Thank you. Well, that's a very, very clear message and goes alongside the very clear messages we had from the other witnesses this morning.